Hello, and thank you for joining us today for the latest Nutrition Advisory Committee webinar titled Early Enteral Feeding Protocols, Standardizing Practice in the NICU. My name is Patty Cadieux, and I will be your moderator today. Before we begin our event, I'd like to go over a few housekeeping items. This presentation will be available on demand at the conclusion of the event, and you can view the replay here at any time afterwards. Turn up the volume on your computer, as there is no dial-in number and the audio is streamed through the webinar presentation. We encourage you to ask questions throughout the presentation, so please send us your questions or messages by clicking on the Ask a Question button. We will review your questions at the conclusion of the presentation. We have detailed slides, so please feel free to use the full screen feature by dragging your mouse to the bottom of the video player and pressing the full screen button. And before you leave, we encourage you to leave us feedback or ratings under the ratings button. Our presenter today is Olivia Mayer. Neonatal nutrition is truly Olivia's passion. As a registered dietitian and lead nutrition practitioner in the NICU at a children's hospital in the San Francisco Bay Area, Olivia is committed to improving the lives of medically fragile infants through nutrition. Her team has been recognized by the American Society for Parenteral and Enteral Nutrition as a clinical nutrition team of distinction. Only one other children's hospital has ever been given this honor. Prior to starting her role in 2006, Olivia gained valuable experience in clinical nutrition roles at the University of California in San Francisco Medical Center and Stanford Hospital. She also served as a dietetic intern at the National Institute of Health Clinical Center, and she is currently completing a lactation consultant certification program through the University of California San Diego Extension. She has co-authored 2 journal articles on feeding protocols for premature infants and is a frequent speaker and educator on this important topic. And with that, I would like to hand over the presentation to Olivia, so please begin.
Hi, I'm Olivia. Thank you so much for joining me today to talk about feeding protocols and standardizing practice in the neonatal intensive care unit. Specifically, we're going to look at the very low birth weight population. To disclose, this presentation was created by and reflects the sole opinions held by the presenter based on research and clinical experience. I received a speaker honoraria from Prolactive Bioscience. Now, for a quick overview of the presentation, we're going to start with why of feeding protocols, followed by literature review. I'll then talk about my clinical experience in implementing and creating feeding protocols, and end with talking about practical applications. So feeding protocols are known by many names, also called a feeding pathway, feeding bundle, standardized feeding initiation and advancement, or standardized enteral feeding. Throughout the presentation, I will probably go back and forth between feeding protocols and feeding pathway. Feeding pathways were focused more on early enteral feeding, which also has many names, such as trophic feeds, minimal enteral feeds, gut stim feeds. And throughout the presentation, I will most likely call them trophic feeds. So what are early enteral feeds? Well, ideally, they're human milk. And the rationale for these feeds is more medicinal than it is nutritional. It's to stimulate gut hormone maturation, gut hormone release, and induce gut motility. We're talking about very small volumes of 10 to 30 mLs per kilo per day. And the absolute ideal would be to start these feeds within the first 24 hours of life. The sort of outside ideal time would be to start within the first 72 hours of life. And these trophic feeds usually continue at these low volumes for about 3 to 5 days, but some places do continue them out for 7 days. Now, why? Why am I so concerned about getting those feeds started? Well, infants who are kept NPO longer create an abnormal physiologic situation that puts the baby at higher risk for infection. When a baby is born, even very low birth weight infants, the GI tract is a relatively mature, experienced organ that has been stimulated in utero with amniotic fluid. And if we can continue that stimulation, we decrease that baby's risk of bad bugs getting in via the GI tract. The benefits of early feeding have been published for quite some time now. They include fewer line days, regaining birth weight faster, promote GI maturity and tolerance, improve bone mass by term age, improve mental outcomes at 24 months corrected age, decreased length of hospital stay, decreased cholestatic jaundice, and achieving full feeds faster. Are there contraindications? Yes. Those would be mostly congenital anomalies precluding feeding, such as omphalocele and gastroschisis, evidence of GI dysfunction, typically associated with hypoxic ischemic compromise, vasopressors, and maybe indocin, although we'll talk about that briefly a little later. Are there limitations? Yes. Mom's milk coming in, or lactogenesis 2. Differences between practitioners in terms of appreciating the difference between the goals of trophic feeds versus nutritive feeds. Again, viewing this more as medicinal than nutritional. Inconsistent definition between providers of what a sick infant is. The more complicated a feeding protocol and/or a feeding algorithm for feeding intolerance discourages people from using these. A lack of buy-in from caregivers and lack of access to banked breast milk could also limit the implementation of a feeding protocol. Now we'll talk more about the literature. This recent publication comes to us from a group at Nationwide Children's Hospital in Ohio. And what they did is look at the impact of process optimization and quality improvement measures on neonatal feeding outcomes at an all-referral neonatal intensive care unit. All of the infants in their unit were born someplace else and transferred into them. What they found was optimizing the process and implementing a standardized feeding strategy minimized practice variability, accelerating the attainment of enteral and oral feeding milestones, decreasing length of stay without increasing adverse mortalities. They also found a greater weight gain velocity and a decreased time on CPAP in those infants who were placed on the standardized feeding pathway. This study comes to us from a group in South Carolina, and I like it because of the large number of subjects. What they found was starting early enteral feeds decreased the median time feeds were started from 33 hours of life to 14 hours of life. And when they looked at all their data, they found that early enteral feeding, defined as starting within those first 24 hours of life, was significantly associated with decreased NEC or death and less TPN days. This study was recently published out of a group from Albany, New York, and they looked at postnatal growth restriction. What they found was establishing and implementing a standardized evidence-based feeding bundle for all very low birth weight infants resulted in significant reduction in postnatal growth restriction at the time of discharge to home. These benefits were, of course, also seen in extremely low birth weight infants, which are those considered at highest risk for postnatal growth restriction. These authors from Arizona and Nebraska stated in 2013 that on the basis that standardized feeding protocols are simple, cheap, effective, and transmissible, they reduce the risk of NEC, and it is time for the adoption of standardized feeding protocols, that it's no longer optional but imperative in our quest to prevent NEC. The etiology of NEC is still relatively poorly understood. It's multifactorial, and because greater than 90% of infants who develop NEC were enterally fed, prevention of this disease relies heavily on feeding practices. This study that came out of Australia in 2005 was a meta-analysis, and they concluded that standardized feeding regimens may provide the single most important global tool to prevent and minimize NEC in preterm infants. The Cochrane Review, published in 2013, found that starting early enteral feeds did not result in a statistically significant effect on the incidence of NEC. Another Cochrane Review, also published in 2013, looked at the delay of early progressive enteral feeds. And what they found is that it did not have an influence on NEC, but what it did have a statistical significantly effect on was a delay in achieving full enteral feeds. The longer it takes the baby to achieve those feeds, the longer they have a central line in place. In 2012, the American Society for Parenteral and Enteral Nutrition published guidelines that recommend minimal enteral nutrition be initiated within the first 2 days of life and advanced by 30 mLs per kilo per day in infants over 1,000 grams. These two studies listed here are a little bit older, but what they both come to conclusions is that feeding small volume enteral feeds during treatment of PDA with Indocin may not be as dangerous as previously thought. In fact, they both found giving small volume enteral feeds actually decrease an infant's risk of NEC. These three studies listed here found that giving small enteral feeds while an infant has a UAC actually decreased the incidence of NEC. The use of a feeding bundle appears to reduce central line utilization in neonates. This recent publication found that implementing a feeding bundle did significantly decrease central line utilization in all very low birth weight groups. In this study, the CLABSI rate was unchanged. However, implementing this feeding bundle resulted in decreased central line days, which further decreases an infant's risk for other invasive infections. Late enteral feedings associated with intestinal inflammation and adverse neonatal outcomes was just published by a group in Boston, and they found that delaying enteral feedings beyond the third postnatal day was associated with an increased risk of chronic lung disease, increase in retinopathy of prematurity, and an increase in multiple comorbidities compared to infants that were fed on or before the third day. Additionally, they also found fecal markers of increased inflammation. So now that you've started your feed, where do you go from here? How do you advance? Do you advance slowly or a little more rapidly? This is a very small study out of Germany, and it's a retrospective single-center study. And what they found was that the faster the feeds were advanced, the sooner those infants achieved full feeds. This Cochrane review, again, is a meta-analysis of 5 randomized controlled trials. This was published in 2013, and they looked at daily advance of slow versus fast volumes. And while they did not detect statistically significant effects on the risk of NEC or all-cause mortality, again, they showed that the slower the feedings are advanced, the longer it takes to achieve full feeds. This is a recent publication that looked at a standardized slow enteral feeding protocol and the incidence of NEC in extremely low birth weight infants. This comes to us from a group in Cleveland, Ohio, and they found that a standardized slow enteral feeding protocol significantly reduces the incidence of NEC and combined NEC or death in infants with birth weights less than 750 grams. Now, while it took longer for them to achieve full enteral feeds on the protocol, the surviving extremely low birth weight infants did demonstrate comparable weight gain at discharge without prolonging their hospital stay. These authors argue that it's actually the slow feeding advancement that's associated with NEC reduction versus the initial MPO period. If we're talking about feeds, the topic of high residuals is going to come up. And we all know that they are very common, it's physiologic, and these 3 studies have shown that excessive gastric residuals nor color differences in gastric residuals are shown to predict feeding tolerance. Now for my clinical experience. In 2011, we published an article that showed improved outcomes with a standardized feeding protocol for very low birth weight infants. You can see our study flow here and which babies were excluded and for what reasons. In the end, we ended up with 83 babies before the initiation of the protocol and 64 babies after the feeding protocol was initiated. Here, you can see our nutrition outcomes before and after the implementation of that protocol. And you can see that feeds were started earlier, significant enteral feeding volumes were reached earlier, and the duration of TPN was shorter in all of our very low birth weight infants. When we exclude the bigger ones and just talk about the extremely low birth weight infants, the results are even more statistically significant. Our enteral feeds did start slightly earlier, but the time to reach 120 mLs per kilo per day, 160 mLs per kilo per day was statistically significantly shorter, and the duration of TPN was cut by over 2 weeks. Our NEC rates also statistically significantly reduced, and you can see that we had no NEC in our 1,001 to 1,500 gram babies. Our results for the rate of late onset sepsis was also significantly reduced, And as you can see, we had no late onset sepsis in the babies who were 1,001 to 1,500 grams. This slide shows the average daily enteral feeding volumes during the first 28 days of life before and after implementation of a standardized feeding protocol. On the bottom blue lines, the dark blue squares show the extremely low birth weight infants after the feeding pathway was introduced. And you can see we started very slowly, but by the time we got to day of life 28 and 27, we were significantly ahead volume-wise in their enteral feeds, and they're likely to be off of TPN compared to before the feeding protocol was introduced. For the 1,000 to 1,500 gram babies, they are the green lines, and the lighter green line, you can see that was after the feeding protocol was initiated. And we advanced much, much slower than we had before the feeding protocol implementation. However, at the end, we also were at larger volumes than we were before the implementation of the feeding protocol. Looking at this data prompted us to update our feeding protocols and showed us that we could probably advance those bigger, very low birth weight infants a little bit faster. So now, where do you start if you don't already have a feeding protocol or feeding pathway? Step number one would be to establish your criteria. Who is your target audience for this? Is it going to be all very low birth weight infants, less than 1,500 grams, less than 1,250 grams, or less than 1,000 gram babies? Our APGAR score is going to be part of your criteria. And what about small for gestational age? Will they have their own feeding pathway? Are you concerned about absent end diastolic flow and establishing early enteral feeds? And obviously, some anatomic malformations will exclude very low birth weight infants from these feeding pathways. The second step you're going to want to look at is your human milk availability. Is mom in-house, just down the hall or on a different floor, or is mom still at the outborn hospital? Do you have access to her breast milk? If you don't, do you have access to banked breast milk? Banked breast milk should be used in these infants. And are you going to use it until mom's own milk is available? And obviously you will use this if mom's own milk is unsafe to feed the baby. Now where are you going to start? What volume will you start at? 10 to 20 mLs per kilo per day? And how long will you keep that minimal enteral feed, that trophic feeding volume? 3 days, 5 days, or even 7 days? Now when will you advance? Will you advance daily? Will you advance every other day? And by how much will you advance? I strongly recommend writing in breast milk fortification as part of the feeding protocol. So first, decide what volume do you want to start the fortification. Are you comfortable with starting at a lower volume, or do you want to wait till a larger volume? And what product will you start with? Many institutions find starting with a human milk-based human milk fortifier has been very safe and very effective at a much lower volume versus using a bovine-based human milk fortifier. I recommend implementing these feeding pathways as an automatic order set so that all you have to do is push a button to order this. But when will you push that button? On admission? At 24 hours of life? Or within the first 72 hours of life? Or do you have your own criteria and want to leave it up to the provider discretion? You obviously also need to come up with stopping criteria and guidelines. What is unacceptable? An emesis volume, number of emesis, a distended abdomen. Are you worried about residuals, or is there other criteria you will stop? And finally, give it time. Evaluate your feeding pathway. Figure out what works for you and what does not work for you. It's hard to start a new practice, and you need to give it at least 6 months to a year to really give it a good go to see if it helps you to become more successful in feeding your infants. This article calls out many obstacles to implementing a minimal enteral feeding pathway. It addresses workflow issues and caregiver or practitioner attitudes and education regarding the importance of starting minimal enteral feeds. And as part of this, they give a very thorough appendix that included their own criteria and guidelines and feeding protocol. Finally, to conclude, the benefits to the patient are numerous, starting with decreased length of stay, decreased central line days, The sooner the baby goes home, the happier mom and dad are, and the happier the hospital is. Any pathway is better than no pathway. Having a pathway helps with communication and minimizes provider variability. And finally, each and every baby has their own hospital course. Feeding pathways are not set in stone, they can be discontinued, and each baby needs to be closely monitored, evaluated, and they may need alterations to his or her feeding advancement. Thank you so much for your time.
Thank you, Olivia, for your very insightful presentation today. If you'd like additional information on anything that was presented, please email us at info@prolacta.com or visit us at prolacta.com. Now we'll jump right into the question and answer session. If you have questions, please use the Ask a Question button, and I do see many questions coming in. Our first question is, infants are being fed at 24 weeks gestational age. Are their guts mature enough to accept enteral feeding? Olivia?
Yes. First of all, excuse my voice. I seem to have lost it. But at 24 weeks, it's a mature organ in their gastrointestinal tract, and it's absolutely appropriate to try to start feeds at that time.
Excellent. Second question is, are there any circumstances during which you shouldn't feed these infants early?
Yes, if there are some GI anomalies, such as gastroschisis and phalloceal, if they are too unstable and on a lot of vasopressors, those would be times where you would not feed these babies until they were stable.
I understand. Third question, did the feeding protocol your institution introduced only address the timing and volume questions, or did you also specify the specific types of feeding to be initiated, such as type of fortifier or formula or 100% human milk?
Yes, all of our babies on all of our feeding protocols are to start using mom's own milk. And if we don't have mom's own milk, we do have access to banked milk, and we'll use banked milk. If mom's milk is not available or it's unsafe for whatever reason, it is an automatic advance. And yes, we have fortification written into the feeding protocols, and we are using a human milk fortifier to fortify our infants less than 1250 grams once they reach 100 ml per kilo per day.
Excellent. Also, have you incorporated an exclusive human milk diet into your feeding protocols at your hospital?
Yes, by using both mom's milk and donor milk and a human milk fortifier. Those infants do typically get exclusively human milk fed through at least 34 weeks of age.
And what outcomes have you seen as a result of implementing an exclusive human milk diet?
Sure. So when I started in 2006 in the NICU, our NEC rate was 8%. And since then, we have implemented many things, and our NEC rate has continued to come down over the years. Since implementing the feeding protocol, I have noticed that not only has our NEC rate gone down, knock on wood, it continues to stay low, but also I feel like we start and stop our feeds less often. So typically we're able once we get on to stay on and stop TPN sooner and get those lines out.
Excellent. Another question here. Have there been any identified outcome differences between pasteurized breast milk versus mom's own milk?
I'm a little unclear about what you mean by outcomes on that in terms of growth outcomes or developmental outcomes.
It's not clear in the question. This came from an outside came in
Sure.
from the outside, but again, I'll repeat it. Have there been any identified outcome differences between pasteurized breast milk versus mom's own milk?
As far as I know, the effects of human milk are the same, whether it's donor milk or mom's own milk. Uh, there is a lot of debate about the nutrient content of donor milk or banked milk or pasteurized human milk versus mom's own milk that's not been pasteurized. Uh, However, I think in terms of outcomes, the neurodevelopmental outcomes, uh, long-term cardiovascular outcomes are in favor of human milk, whether it's mom's own milk or it's pasteurized and donated milk or banked milk.
Thank you.
Mm-hmm.
From one of your figures presented,
Mm-hmm.
a questioner here noticed that your hospital reached full enteral feeds around 40 days after implementing the feeding guidelines. Did you have a good growth pattern?
Yeah, so we have improved our growth every year since 2008 by about 1 gram per kilo per day. So now our average growth rate is close to 15 grams per kilo per day in those infants, in our very low birth weight infants. So yes, our growth has continued to improve. Again, not just with the feeding strategy, but implementing TPN earlier and things like that. I think just becoming more aware. There was a period of time where we did not use any fortification at all, about 2009. So we did not use any bovine nor human milk fortification at that time. And despite that, our growth continued to improve.
Excellent. Another question here is, let me see, they're quite coming in quick here. Of the studies that did not have an increase in neck, do you know what type of fortifier they used, human versus bovine?
So that's a great question, and I can get back to you on that specifically if you leave your email. I believe in most of them it was a bovine-based human milk fortifier, but there are some studies that, yes, are include infants who just use an exclusively human milk diet and a human milk-based fortifier.
Excellent, thank you. It says, at your facility, do you use a liquid protein fortifier, and can you share your parameters for use?
Sure, that's a great question. So yes, we have been using the liquid protein fortifier, and when we typically use it, we will use it in infants greater than 1,500 grams, and if babies were less than 1,500 grams, we will not use it until they're 34 weeks of age. And our parameters for using are, well, first, we will try to maximize volume of feeds up to 200 mLs per kilo per day if we can, if the baby tolerates it. If their growth is a little slow, their BUN is, let's say, less than 8 or 9, we might just add the liquid protein fortifier instead of using the entire bovine-based human milk fortifier. The other times that we will use the liquid protein fortifier is in some of our renal babies. We've used it, and typically it's just added to mom's own milk. It's rarely added in addition to fortifiers of any kind.
Excellent point. I have a number of folks here who have asked about making the references available, and certainly those will be made available to you on the slides. And the slides here will be available as well after you're able to access the webinar again and review it and see the slides again after the conclusion of our talk today. So with that, there are folks, as I said, who are looking for complete references. If there are no more questions, I haven't seen any more come through here. So if there are no more questions, we'll conclude the webinar. Should you have additional questions following the conclusion of this webinar, please email them either to info@prolacta.com or to my colleague, Anna Lay, and her email is ale@prolacta.com. And you can get your answers to your questions. They'll be filtered over to Olivia for review and response. So with that, thank you everyone for attending today, and thank you, Olivia, for your presentation, your insightful presentation. It's been very enlightening for all of us. Thank you so much for your expertise and your insight.
My pleasure.
Thank you.